Good afternoon, and welcome to Lynn Cancer Institute Updates, what you need to know in 2021. We're very grateful to have all of you with us today and to learn from our very own Dr. Sajeel Chowdhary. Dr. Chowdhary will be educating us on benign brain tumors and meningioma. At the Lynn Cancer Institute, we believe that education, prevention, screening and early detection, a variety of treatment options, the expertise of our staff, and our latest technology will truly save lives. In the interest of time, Dr. Chowdhary's bio was sent to you by email. We invite you to please take notes, and when you have a question, please write it in the Q&A or the chat box. Dr. Chowdhary will not be able to see or hear you during the presentation, so your questions must be written in the chat box in order for him to see and respond. Your Zoom will be muted during the presentation. There'll be time at the end of the presentation for your questions to be answered. You will also be receiving an evaluation sheet. These evaluations allow us to add your name and email address for future mailings, as well as to address any questions or suggestions that you might have for us. Lee will email this evaluation along with the quick link to today's lecture, probably by Monday. Now, we're very proud to welcome you to the Lynn Cancer Institute and to introduce Dr. Sajeel Chowdhary, Director of the Neuro-Oncology Program at both the Lynn Cancer Institute and the Marcus Neuroscience Institute at Boca Raton Regional Hospital. Welcome, Dr. Chowdhary.
Okay, great. Jan, can you hear me? Can you guys hear me?
Yes, now we can hear you. We couldn't hear you before.
Perfect. So our good friend Lee was trying to help us, and I think we got everything done. I'm going to increase the volume a little bit here. And all right, so thank you for the great introduction there, and great honor. And I was just mentioning to a good colleague a little bit earlier that admixed with our patients and our clinics, one of the things that as good doctors and good healthcare providers that we enjoy the most is actually teaching our students, teaching our patients. And so a great honor to be here, and thank you for the invite. And I'm hoping that this will be the first of many lectures that we present together. Now, I was given the task to speak about benign brain tumors, and we often speak about the more malignant forms of brain tumors, and those are, of course, important topics as well. But out of curiosity, it's really those benign entities that fortunately we see far more commonly or far more often in our brain tumor clinics. And most that know me, I did my neurology training at the Cleveland Clinic, where the neuro-oncology program was very robust. And we actually saw a very large volume of meningiomas and acoustic neuromas, which not always, but generally are seen as benign brain tumors. Now, I do not have any financial disclosures. As some of you may know, J.K. Rowling is the designer, if you will, or the author of the Harry Potter series. And I must confess that I haven't read the books, but I might have seen a few of the movies. But some of you may or may not be aware that J.K. Rowling was also, or is also, very famous in writing some quotes. And if you know the story of J.K. Rowling, she herself went through a lot of life challenges before she got to a point that she was able to write her books, and then the movies ensued. But this presentation, hopefully I'll be able to get through most, if not all, of the slides. I have two very good J.K. Rowling quotes, and I believe that this quote, pretty much encapsulates our workday in a neuro-oncology clinic or an oncology clinic in general, that as good doctors, as we are trained, and I'll confess myself, we never want to accept failure, and success for us is to cure human disease. But failure is a part of our life, and failure is a part of our life of the of the general human being soul, if you will. But it's an opportunity. It's an opportunity to learn, and I believe what J.K. Rowling is trying to mention here, that that of course, as good human spirits and good human souls, we never like to fail, but we can learn from failure, and it must make us smarter, and it must make us stronger. So when we speak about benign brain tumors, this is by no means a complete list, if you will, but it probably tries to it tries to uh, encompass the more common benign brain tumor types. Meningiomas are probably, in a vast majority case, are the majority of benign brain tumors that we see. And hence, I will spend most of my time today speaking about meningiomas. But acoustic neuromas, we see a fair number of acoustic neuromas, pineal tumors, choroid plexus tumors, pituitary tumors, and hemangioblastomas. Now, of course, as I mentioned before, this by no means is a complete list, but it actually covers a lot of the bases. Now, I see quite a few of meningioma patients in the hospital and in our neuro-oncology clinics on a day-to-day basis. And when you look at the cross-section of meningiomas, the vast majority of meningiomas are essentially benign meningiomas, or as we term them as World Health Organization grade 1 meningiomas. And as you can see, about 90% of meningiomas that we will see in a good neuro-oncology program, academic programs and semi or community neuro-oncology programs, majority of them will be grade 1 or slow growing tumors. Now, it would also not be fair to say that all meningiomas are benign. There's a small fraction, about 10% of them, that can be a little bit more malignant, if you will, compared to the more benign subtype. About 7% of meningiomas are atypical meningiomas, or as we term them, as World Health Organization grade 2 meningiomas. And then a very small fraction, fortunately so, are World Health Organization grade 3 meningiomas. They're anaplastic meningiomas. Now, in robust volume neuro-oncology programs, you might see one anaplastic or one or two anaplastic meningioma, again, fortunately, per year, but we see about 5 to 10 atypical meningiomas every year. And if time permitting, I'll attempt to speak about the management and the tumor biology of atypical meningiomas as well. But we'll spend most of our time chatting about grade 1 meningiomas, because all true reality, that is the vast majority that we might see. Now, I'm going to quote two real life patients, of course, no names given, that presented in our neuro-oncology clinics over the past 3 to 4 months. And it's a very common entity. I'll get a good phone call from our good ER doctor or a good nurse in the ER or one of our residents that, geez, Dr. Chowdhary, we just did a CAT scan, we just did an MRI, found this tumor. Can you take a look? And it's always a very heartwarming finding when we determine that it's more of a benign entity, a benign meningioma. One thing I wanted to highlight, that meningiomas, especially the benign meningiomas or the WHO grade 1 category, are often calcified. And remember, my good neuropathology colleague, Dr. Richard Prayson, always would teach us that that brain lesions being calcified is generally always a very good thing, because that generally means that that entity has been there for a very, very long time, and it's had the time to accumulate calcification. So not always, but generally speaking, in the brain tumor world, calcification is a good thing. So here you can see a CAT scan, and I wanted to put this picture here that that highlights. And if you have some experience, and many of you might, looking at brain CAT scans, and this is a non-contrast brain CT scan, that calcification, and if you can see the white area around the or the skull bone region is very bright white, and then you can see that meningioma tumor in the left frontal lobe is also almost as white as the skull bone. So that entails the fact that this tumor is calcified. And this, generally, when I see this particular image sent by the ER doctor or go into Cerner in our EMR system to review, this is a very welcoming sign, and this is a very positive sign. So this is one of those good cases that I actually saw in clinic in the past 3 to 4 months, and a very pleasant lady within her 80s, right-handed, and had a New Year's party at her house. And I remember she described it very nicely, that she moved into a new home, had new furniture, had a new rug close to the bathroom, and one of the guests wanted to use the restroom, and while she was guiding the guest, didn't recognize the carpet that she had just bought, and just had a regular slip and fall, not related to any neurological event, and then didn't think too much of it, and thought, as we all do, that things would just get better. And then a few days later, her family convinced her to come to the ER, and just presented with some lingering headaches. And an MRI was conducted within the ER. Now, what is different about this image versus the CAT scan that we reviewed before, that it's a coronal image, which, if some of you have experience looking at brain MRIs, is basically a cross section that I felt highlighted this area of the tumor. And you can see that it is contrast enhancing, and the tumor in the left frontal lobe is coming off the dura, which is the thick fibrous sheath, or God's provided mechanism of protecting the brain, and the tumor comes from the dura. But you can tell that the tumor is densely enhancing. So here I wanted to mention one more thing. This is not calcification that's enhancing, but this is the meningiomas that generally enhance very, very easily. Now, some of you who do neuro-oncology, or do oncology in general, might equate enhancement to the tumor biology being more aggressive. But in meningiomas, it's the opposite. And so that the philosophy is true often, but that philosophy is not always true. So meningiomas, that they're benign entities, but they're densely enhancing. So here's one good teaching point, that not every brain tumor in the brain that's enhancing always has to be aggressive. So this is a very fortunate finding. And so by just looking at the MRI, by just looking at the image, I was able to counsel the patient that this is a good save. This is a good looking MRI, most likely a benign meningioma, and we don't have much to worry about. Now, often the question, and a good family doctor in our community had referred this patient to me, and after describing the patient, after I had a chance to evaluate the patient, and she looked great, the next question that the good family doctor asked is, geez, what do we need to do? Do we need to do surgery? Do we need to do radiation? Or is there any aggressive therapy that needs to be done? So the age-old question is, do all meningiomas need to be treated? So we recognized this question about 20 years ago or more. And so there are some really good classifications that we follow, in which we do risk stratification, which that really means, as you know, is that if someone is in a low risk category, perhaps we just need to do surveillance. And if someone is in a higher risk category, then perhaps we need to treat those meningiomas a little bit more proactively. And I'll talk more about what that proactive treatment might mean, even though meningiomas are generally, as you may recall from 2 or 3 slides ago, that a vast majority, 90% of meningiomas are World Health Organization grade 1 meningiomas, hence benign entities. So when we look at the risk stratification for these benign entities, tumor size, as you would imagine, even a benign tumor in a tough location of the brain and a certain large size and causing edema, as much as good neuro-oncology, as a good neuro-oncology team might be able to say that it's still most likely a grade 1 meningioma, but if the size is large enough and it's already invoking pressure on the brain, and of course we look at those acute impending complication risks like hydrocephalus, which, as some of you know, or most of you may know, is increased pressure within the brain. And I always like to caution, I wanted to make that point there, that the human brain and neuro-oncology, that's what makes this specialty very unique, in my humble opinion, and also very special on the same token, that you could have a tumor of another part of the body, but there's a lot of room, there might be, and we don't want any tumor to grow, but there might be a lot of room for it to grow. But the way nature created the human body, that the brain is very protected because it's a closed cavity, if you will, that the tumor growth can only expand in a couple of directions. It cannot expand outwards per se, depending on what the location of the tumor might be, because the skull cavity or the calvarium or the calva, which is the skull bone, will actually contain it. So the tumor is not able to grow in that direction, but the only direction it can grow is towards the brain itself. And if it's close to very crucial structures like the optic nerve and the optic pathway or the brain stem, which is basically which is the converging point of all those nerve fibers going down to the spinal cord, or we even see spinal canal meningiomas that are actually off the dura, as you may know, and I should have explained that earlier, that the dura, or the thick membrane which is protective to the brain, also goes all the way down to the spinal cord. So we every so often, not commonly, but every so often, we'll see spinal cord meningiomas that are again grade 1 benign entities with risk of spinal cord compression. So if we are fortunate enough to detect these tumors, even if our good patient is asymptomatic, and we live in Boca, very blessed, where we have amazing patients that are over the age of 75 but doing amazing things. So age is not a factor. Actually, I'll confess, in the olden days it certainly used to be. But if a patient is healthy, they're enjoying great life, and we incidentally detect a tumor that is of certain significant size, that we are concerned, there's edema, or is close to the brainstem or the optic pathways, or any other, um, uh, eloquent structure, then we might even be preemptive and recommend surgery or recommend to proactively approach that tumor. Now, this is a good point to talk a little bit about the neuroanatomical features, that where do most meningiomas occur? And Harvey Cushing, as you may recall, who was a very talented brain tumor surgeon, passed away in the 1940s. And many of us argue that perhaps changed the kind of like the Wayne Gretzky of playing hockey, and Harvey Cushing really changed the field of neuro-oncology or neurosurgery in general. And these were actually some of Harvey Cushing's original descriptions, that the most common location of these meningiomas, wherever the dura, or that thick membrane that protects the brain, exists, you can see meningiomas. And not to spend too much time here, because time is limited, and I'd like to get through as many slides as we can. But just to give you a little, just to highlight that these meningiomas can occur anywhere, and it's the skull-based meningiomas, which I wish I had a pointer, but with Zoom calls, hard to do that. That I could show you those areas that many of these meningiomas can occur in the skull-base region, as the olfactory groove, the optic chiasm, cavernous sinus, the brainstem, cerebellum, etc. So many of them can be in areas that, even though they might be benign tumors, but the location where they might be are very high risk zones. So it's kind of like real estate, that it depends where the tumor is. If you're in downtown Chicago, a small apartment will be expensive versus in a suburban region. So the skull base area is a hot spot, and the real estate there is very difficult and very expensive. So a tumor being there will certainly be a very high risk zone, if you will. It's a good time to talk about our second real live patient that I was able to see in our neuro-oncology clinics just a few months ago. Here's another lady who is actually left-handed and is in our field of neurosciences and probably psychiatry, if you will, that we always focus on that right-handedness and left-handedness because of our dominance of the hemispheres. And so here's a 75-year-old who is left-handed, is an online college professor, is a very active swimmer. And while she was swimming, recognized that her left side of her body, which was her dominant side, that was just not as strong as it used to be. Otherwise, no other symptoms, and was very responsible enough to go to a doctor, and a good neurophysician, neurologist in the community. I won't give his name, great guy. He evaluated the patient and noticed some left-sided weakness and upper motor neuron signs. So this neurophysician did a great neurological exam, as it should be, and before even calling me, elected to do a brain MRI with contrast. Now, this really embodies what we were chatting earlier, that here's another MRI, coronal, so comparable to the one before, different scenario, of course, coronal image, T1 axial with contrast, and you can see a densely enhancing tumor coming off the dural membrane in the right frontal lobe. And again, what you can notice that there's a dark shadow below the convexity margin of the tumor, which is basically something we term as vasogenic swelling. So it's edema, and it's basically that abrasive effect, effect, and that pressure being put on the brain itself. And the human brain is very fragile, and I guess many tissue, or a lot of different tissues are, but it doesn't like to have any pressure put on it, and it only reacts in a few different ways. One is that it can cause swelling, and of course, as the swelling pushes, and I wish I could highlight that a little bit better, but you can see that fox cerebri, which is the midline dural structure, is pushed over to the left side. And you can also see that the lateral ventricle on that right side is not symmetrical. It's not like the left lateral ventricle might seem. So you can easily see this MRI, and you can tell that, although, albeit agreed, this 90% chance this is a benign meningioma, but it's not behaving in a benign fashion. Well, not that it's not behaving, but it's grown to a certain size, pushing over to the opposite side, that this may not be a scenario that we want to sit on the sidelines and just watch and wait. And the patient is having symptoms, 75 in Boca. I always say it's 55. She's very young. She's a college professor. She's left-handed, so it's implicating, or it's leaning on her dominant side. So we need to be proactive here. So, and that brings us to a great section. What are the high risk stratifications? And some of them we already spoke about. Size matters here. Mass effect, that vasogenic edema and midline shift. The patient is symptomatic. And also we must factor in if the patient is a good surgical candidate. And this patient fortunately was. And hence, in this particular case, we would recommend a term we use in neuro-oncology. And if you come to our CNS tumor boards here at the Lynn Cancer Institute, by the way, which is today at 1 p.m., we have it every week, that we often speak about this term, which is a really very complete term, if you will, that we want to do a maximal surgical resection, but a safe surgical resection, hence a maximal safe surgical resection. And then recommendation will always be based after a good neuropathological review. And because, yes, we are presuming and assuming that this will be a grade 1 meningioma, but it could also be a grade 2 atypical meningioma or an anaplastic meningioma, which are grade 3s. 3% or less of meningiomas will be anaplastic meningiomas. So we'll wait on the grade of the tumor, and hence this patient, after I evaluated, was referred to one of our good surgeons and had a surgical resection, had a great outcome, and it did turn out to be a grade 1 meningioma. So after a good resection, I should have had the postoperative film there, but you'll have to just trust me here. So let's talk a little bit about surgical options, and forgive me if I go a few minutes over, but I'll try to get through a few more slides. So what are the usual surgical options for these tumors? Even the days of Harvey Cushing, who did good operations, you know, a neurosurgical technique, as all of you know, has improved drastically in the past 20 to 30 years. And we now have a lot of fancy toys or a lot of abilities to maximize our ability to be able to remove not only meningiomas, but all kinds of brain tumors. You know, our ultimate mission, as you know, is threefold: to decompress, remove a brain tumor, and improve patients' outcome and their functionality, first and foremost, and do what's best for the patient. Number two is to get a pathological diagnosis, to know what the tumor is, and if it needs further treatment as radiation, systemic therapy, clinical trials, etc., or not, we need to know that. And so those are our two basic principles why brain tumor surgery even should be done. Now, there's a philosophy there. We spoke about maximal safe surgical resections, but there's a philosophy now, and if you go to our good neuro-oncology meetings, of doing supramaximal resections. Now, for meningiomas, there's a little bit of focus there, but for gliomas, and that's not our topic today, and maybe one day we can speak about high-grade gliomas, but I just wanted to put that in your minds that there's a lot of hypotheses and a lot of excitement in the academic and within the academic neuro-oncology arena to consider supramaximal resections. And the whole reason why we speak about supramaximal resections is that not for meningiomas, perhaps for anaplastic meningiomas, that you can do a great resection, and then lo and behold, whether treatment was needed or not afterwards, that at some point you might recognize 6 months later, a year later, 2 years later, that the tumor is starting to recur and there's tumor recurrence. And so how do we prevent tumor recurrence? Maybe there's microscopic spillage of tumor cells at that margin of the brain tumor and the normal brain itself. And perhaps you can go beyond what you see on the MRI and do supramaximal resections. Now we have, I mentioned about some toys and tools. We have some amazing toys and tools now. And in our hospital, we have an intraoperative MRI in which we, during surgery, which is quite amazing, that that everything is not non-ferromagnetic, meaning that's MRI compatible. The whole OR is MRI compatible. And after a good surgeon does a good operation, patient is, while that craniotomy flap is open, taken into the MRI suite. Well, the MRI is right there. It comes out of the wall. And then you re-image because the brain settles after surgery. You might miss something. And then there's good data from good programs, and ours included, that that often intraoperative MRI can be extremely useful to maximize maximal safe surgical resections. Often we also use very smart technology like MRI technology, like MR spectroscopy. There was a study that might be coming out, one of the national consortia that we're a part of, that will be looking at MR perfusion and MR spectroscopy, both we do here, that to maximize surgical resections. 5-ALA, and I won't spend a lot of time on 5-ALA because it's more for gliomas or glioblastoma surgery, but there is a isomer, if you will, or a variant form of 5-ALA, which basically highlights where that microscopic tumor cells might be, and it guides a good surgeon to maximize surgical resections and go where no man has gone before, if you will, or go where the MRI doesn't show it, but if you go further, you'll capture those microscopic cells and prevent tumor recurrence. Now, radiation has a lot of role to play with meningioma surgery and with or without surgery, or meningioma treatment. With or without surgery, radiation has a very large role to play. And essentially, depending on the size or depending on the case scenario, and when we can spend a lot of time on radiotherapy options or how to be able to conceptualize radiation for these particular benign tumors. But I must say, in very broad strokes, there is photon-based intensity modulated radiotherapy, which is basically fractionated form. And I remember coming out of fellowship where IMRT was quote unquote experimental, but now IMRT is standard of care. It's very conforming, very safe. Stereotactic radiosurgery, or SRS, CyberKnife or Gamma Knife. CyberKnife is what we do here, and again in very broad strokes, CyberKnife and Gamma Knife are very identical, but it's a mechanism of delivering pinpoint radiation, or quote unquote simplistically spoken, smart bombs, and we can drop a large dose of radiation in a small tumor. Now, another famous question, as all of you might be thinking right now, is proton beam therapy superior to photon-based therapy? And we are not a proton site, but I've heard some good rumors that we will be a proton site soon, although our partners at Baptist Hospital South Florida at the Miami Cancer Institute, there's a proton center. When we have patients that need to go for protons, we send them down to Miami, but God willing, we'll have a proton center right here at the Lynn Cancer Center. And but proton beam therapy, there are trials ongoing. We don't know the final answer right now if proton beam therapy is superior for meningiomas, at least for pediatric brain tumors, for optic nerve gliomas, for chordomas, for craniopharyngiomas. There's a lot of good data that proton beam therapy for pediatrics and adults is superior, but for meningiomas and for gliomas perhaps, and again, clinical trials are ongoing, and we were part of one of those trials that will know with time if protons are superior to photons. But the wave and the times of change and the way the wind is blowing, it feels like having ability to do proton beam therapy will only be a big addition to our weaponry, if you will, against brain tumors in general, not only brain tumors, but other oncology in general as well. Now, I wanted to highlight a little bit, and perhaps at 12:40, we're going to come to a hard stop because I've gone 10 minutes over already, that there is some brachytherapy, if you will, or local therapy, gamma tile, which is a technology that we're trying to acquire, and God willing, we'll have it soon. That is basically, I'll go back. That is basically after surgical resection, and we usually are proposing to use it for meningiomas, CNS metastases, and gliomas, mostly recurrent gliomas, and newly diagnosed gliomas as well, in which a good surgeon removes the tumor and then pastes these radioactive biodegradable polymers and into the surgical cavity to deliver local radiation, or if you will, targeted radiation to that area. And there's a good company that makes this technology. It came out of the Barrows Neurological Institute in Phoenix, Arizona. And we are in touch with the company. We're trying to go through all the items that we need to go through to get this technology on board, and we're hoping we might be able to have it. I also wanted to highlight that NRG and Alliance are two of in two of in two of the largest national consortia that are NCI funded that we do clinical trials. We are sites for NRG and Alliance, or we are sister sites, so we have access to opening their trials through CTSU or through our partnering institutions. But overall, at the end of the day, it's very nice that we have access to NRG and Alliance trials. And even though neuro-oncology, if you include CNS metastasis, might be
Oh, no.
only about 25 to 30% of oncology in general. But if you look at the cross section of brain tumor clinical trials that NRG and Alliance proposed to the CTEP, which is a federal organization, or NCI, there about close to 30% of clinical trials at Alliance and NRG are actually neuro-oncology trials. So this highlights that there's a lot of active academic interest in that academic world. Now, I'm just going to review this slide and next slide, and then we're going to, Jan, we're going to, Gary, do a hard stop there. And so there's another really interesting technology that is live and open and ready to use in our site, something known as laser interstitial thermal therapy, or LIT. And there are two different technologies out there. One is known as NeuroBlate, which is the one we have. And there's another product that's a Medtronic product known as VisualLase. But NeuroBlate, they both say one is better, but I think both are equally good. And it's basically thermal ablation. So it's not really a laser by that physics principles, but it's local thermal ablation of tumors. And another entity that we don't have time, and forgive me for doing this to mention something but not have time to explain it, something that we term as post-therapeutic necrosis. In most instances, radiation-induced necrosis. And this thermal therapy, or LIT, can also rectify and address and treat quote unquote necrotic areas as well. Now, it's a 4 millimeter probe. Intraoperative MRI ability is preferred, but they have a robot available as well that, without the intraoperative MRI technology, we can deliver this laser. So it is a neurosurgical procedure. It's under general anesthesia, a 4 millimeter burr hole. The probe is inserted, as you can see in this cartoon, into the core of the tumor, and with the thermal ablation, we can treat these tumors. Dr. Shang, Veronica Shang out of Yale, has done a lot of good work with this. And we have it available, and we actively screen patients for it. So there's another therapy that we can utilize for these tumors. So, a lot more can be said. It's a daunting task to cover in 30 minutes. I went over by 10 minutes. So, Jan, I will forgive me for taking extra time, and maybe we can continue some other day. But I will stop there.
Okay, Dr. Chowdhary, there are a couple of questions from the community. Do you have time to answer questions?
Yes, please.
Okay, the first one is, I have heard several times that people having lung cancer suddenly develop brain cancer. Is that simply because of location or some other factor?
Well, true, and I'm presuming that this is a great question, and I'm presuming it's CNS metastasis from lung carcinoma. And there are three tumor pathologies, and there are more beyond that, but three most common: melanoma, lung carcinoma, and breast carcinomas. And there are subtypes that might have a higher propensity of CNS metastasis, but unfortunately, these three tumor subtypes have a high incidence of, and we don't know why. Some we understand, but some we do not understand perfectly. So at that scientific level, they have a high propensity of metastasizing to the brain. And so the answer is yes, that not all, but some patients with lung carcinomas can develop brain metastasis. And that's why those patients must follow with their oncologists on a regular basis. And that's an interesting question, because the question often comes up whether patients with other tumor types like lung carcinoma, melanoma, renal cell carcinomas, breast carcinomas, lymphomas, etc., should they be getting screening brain MRIs on a regular basis? And the answer right now is no. They need to be followed by good doctors, followed by the oncologists, good neurological exams, good physical examinations. And if the index of suspicion is high, then they should see an oncology team, or a brain MRI or CAT scan could be ordered. But the short answer is yes, unfortunately, many of our lung carcinoma patients can develop brain metastasis.
Okay, and one more. When a tumor is removed, does the brain simply refill the area that was compressing the brain?
So yes, that's a great question, and actually that's a great question. And depending on the size, and often I've seen both scenarios happen for smaller brain tumors, like the first case that we discussed, in which we did not elect to operate. But if we would have, for any reason, and if it was removed, it probably would not leave any little space there. The second real life scenario that did have surgery, and if I had the post-op MRI, it can leave a cavity, and it gets filled with normal spinal fluid that's sterile, and no harm, no foul. So we just watch it. And it's also, that question is interesting as a second layer, that in pediatrics, and I did pediatric brain tumor work in one of my previous places, that perhaps because of their stem cells being more active, that they can actually regenerate. So often you will see a remainder cavity that might stay there, but it generally is something that we can just watch, and no harm usually comes from that.
Hey, thank you, Dr. Chowdhary. We really learned so much from you today, and we're so grateful. All of our lectures are recorded. So this presentation, as well as all of our past in this series, are posted on our website. So you can watch today's presentation again, or share it with family and friends if you like. Lee will be sending the link to all of you who are registered in her follow-up email. We appreciate everyone that has joined us today, and we hope to see you for our next Zoom and Connect, which will be on Friday, May 7th, 2021, and that will be a focus on skin cancers. Thank you, Dr. Chowdhary, and everyone have a great afternoon and a great weekend. Bye-bye.